Good morning. Thank you so much for joining us on our Facebook Live discussion here on the WMER2 News Facebook page. I'm Megan Knight from Good Morning Maryland, and today we're talking about breast cancer, as October is National Breast Cancer Awareness Month. And joining me this morning to talk about this topic and get all of your questions answered is Dr. Sara Fogarty. She is the director of the Sandra and Malcolm Berman Comprehensive Breast Cancer Center at GBMC. So Dr. Fogarty, thanks so much for joining us this morning.
Thank you so much for having me. I really appreciate it.
Absolutely. I know we're going to get a lot of good information out of this Facebook Live discussion. And I just want to remind everyone who is joining us throughout this conversation, if you have any questions for Dr. Fogarty when it comes to breast cancer, it could be about treatment, it could be about risk factors, support groups, anything that you have a question about, please leave it in the comment section and we will get to those questions as soon as we can. So, all right, Dr. Fogarty, let's just jump right into it.
Sure.
This is Breast Cancer Awareness Month. So let's talk about being aware about breast cancer, some of the risk factors we need to know about. What are some of the things that we need to be thinking about in terms of breast cancer? Like, does it run in my family? Am I more high risk because of X, Y, and Z? So kind of walk us through some of those risk factors.
Sure. So we see a lot of women in our clinic that are at elevated risk for breast cancer based mostly on family history. I think it's really important for women to know their family history as best they can. If they have first-degree relatives, sisters, mothers, male relatives with breast cancer, it's really important to know and bring that to the attention of your primary care doctor or OBGYN. And then they can be evaluated by us in our clinic for to see what their risk actually is. We use, there are a lot of different computer models that we use to assess risk. And that's what we'll do when you're in the center, to see where you fall. And if you're considered high risk, then we make recommendations about what we can do to follow you and screen you for breast cancer. So really, family history is the most important. We also take into consideration a person's gynecologic history, how old they were when they first got their period, any children that they've had, how old they were at menopause, if they've gotten to that point, if they've ever had any abnormal breast biopsies before with atypical disease, if they've ever had any genetic testing in the family that has shown a mutation. That's always important to know. And that's something we also discuss with them, should they have genetic testing and be referred to our genetic counseling center.
All right. Now, let's just say I know that breast cancer runs in my family, but I haven't detected any lumps. I don't feel bad. Should I still go to, say, like to the breast cancer center at GBMC just to see if I might down the line have it, or is that kind of overdoing it?
Sure. Well, it's always a good idea to talk to your primary care doctor or OB first, but we do have an online link where they can fill out a risk assessment form where you can enter in all that gynecologic history that I was just talking about, as well as family history, to see where your risk falls on that model. And if it comes out as high risk, then to call the center and make an appointment, and we can go over that with you and go over what we recommend then for screening. Sometimes it's extra screening, not just mammograms, but potentially MRIs. Sometimes we talk about risk reduction with a medicine called tamoxifen, which is a pill lots of women in this country take who have had breast cancer or who are at a higher risk for breast cancer. So those are all things we would go over with you if your risk model showed that you came out as high risk.
So essentially, knowledge is power. So never a bad thing to kind of just know where your risk stands, especially if you have a family history with it.
Sure. And that website link is gbmc.org/breast cancer assessment. So you can look at that on our website to fill that out.
All right. Very good. Very good resource to have there. So, all right. So let's say that you are high risk and maybe you feel a lump, or maybe you're just not feeling great. What are some of the symptoms besides maybe feeling a lump that we should be looking for? Again, especially if we know that we are high risk for this disease.
Sure. There's a lot of things to look for that I talk to women about who are at higher risk or who have had a breast cancer diagnosis. Lumps, of course, are the first thing most people think about, but most cancers are small and aren't detected that way. Obviously, mammogram screening is very important, and we do recommend screening starting at age 40 annually. There's a lot of different screening recommendations out there. Those are the recommendations by the American College of Surgeons and the American Society of Breast Surgeons. But besides that, skin thickening, sometimes dimpling or a pulling in, especially when you raise your arms. bloody nipple discharge, lumps under your armpits, redness or thickening of the skin. Those are all things to have checked out if they're new for you. I always tell women, really it's about self-awareness. Those breast exams can be a little daunting and cause a lot of anxiety for women. So really just being aware of something new or different for them is the most important thing, and to bring that to the attention of your doctor.
For sure. Yeah. I was just going to ask if, doing the old self-exam every month is still a good way and a good measure to, prevent this, or maybe catch it early, if you do those self-exams.
Yeah. I mean, there's a lot of data out there about self-exams causing a lot of anxiety and that they're not that helpful. I have a lot of women that do come in saying, I noticed this was different. That silly card you got in health class a million years ago with the circles and the pattern that you're supposed to do in the shower, I think that's really hard. Women get really confused by that, and they don't know what to do and think they're doing it wrong. And I don't think that matters. I think what matters is knowing something's new or different for you, however that may be. And some women get really anxious about actually feeling their breasts, doing a breast exam, even looking in the mirror, raising your arms, taking a look at yourself sometimes can bring up something that's new or different. And it's amazing what that could end up, leading to. So I'm a big proponent of people at least being aware of how they look and feel.
Absolutely. Yeah. I mean, anything that you can do to get a head start on it, especially, and your body better than anybody else. So you'll probably be the first one to detect if something is a little awry or a little amiss.
Right. Exactly.
All right. Well, so let's say, in terms of the, diagnosis, so let's say someone comes to you and yes, they do have breast cancer. Is it still kind of typical in terms of stages, or has anything changed with that over the years?
So staging of breast cancer, when I see people initially, we're looking at a clinical stage. That may not be their final stage, depending on what surgery shows. But staging did change a few years ago to include more factors. It used to be mostly based on size and if a lymph node in the armpit was positive or not. Now it also takes into account what we call prognostic factors, really understanding how this cancer is acting. There's some really good kinds and some really bad kinds, and that makes a huge difference in what we recommend for treatment. And it can also affect their stage. So staging is something I do talk about with women, but when I'm initially meeting them, it may not be the correct or final stage. So it's not like the mainstay of my appointment. It's part of it, but not an absolute when we first meet. So staging isn't the most important part of it. It's really how the cancer is acting, the prognostic factors that we look at.
Yeah, absolutely. That makes sense. So when it comes to determining a course of treatment, I imagine there are a lot of different ways that you can go about that. So what are some of the more common ways that you guys go about treating breast cancer at the Breast Cancer Center there at GBMC?
Sure. Yeah, there are a lot of different ways to treat breast cancer and a lot of right ways, which is good. There are a lot of options for therapy, which in some other cancers isn't the case. So surgery, radiation, sometimes chemotherapy, anti-estrogen therapy, which is a pill. These are all things that we talk about at every appointment. It really depends on the type of breast cancer we're seeing, what recommendations we make. And so it's a very individualized process. And we take a long time discussing with patients what their type of cancer is and what we need to do about it to treat it. Surgery is my role, of course. And so we talk a lot of times about breast conservation therapy, which is a lumpectomy and radiation therapy. That's a part of treatment that we're very committed to here as a center. We really push for breast conservation if we can. A lot of women come in saying, I don't ever want this to come back. Just take them both off. I want mastectomies immediately. And I have to discuss with them why that doesn't matter and why that doesn't always help. And so that's something that a lot of women don't realize and is part of our conversation. Mastectomies are necessary sometimes, but it's much fewer and far between than it used to be. So there's a lot of different ways to treat breast cancer. And we have a really collegial, fantastic team here. We work together so well. My medical oncology colleagues and my radiation colleagues, we really are very close, and we have a very good means of communication and a very streamlined process here to get everyone in to see them and have the appropriate treatment.
Yeah, and it's interesting, you brought up the mastectomies, because I do know some women who have gotten double mastectomies over the years, and thinking just what you said, that it means I'm never going to get the cancer again. So I am kind of curious as to why maybe that's not the best line of thinking that we once had.
Sure. A long time ago, that was all we had to offer. So breast cancer used to be a surgical disease where we did large surgeries to remove as much tissue as we could in the hopes of decreasing recurrence and spread. A lot of times that didn't matter. So we did big surgeries and they still had a breast cancer pop up somewhere else in their body, which is not a curable situation. So what we found over time and lots of clinical trials and examining these options was that that doesn't make a difference in the fact that you can still have a breast cancer recurrence even with a mastectomy. There are some women, of course, that have genetic mutations where the risk is higher of it recurring, or that they've never had breast cancer and desire prophylactic mastectomies, and that's completely reasonable. But it's something that we have long discussions about to counsel them on that. So a mastectomy is not, that part of their treatment really isn't the mainstay anymore. Surgery isn't the mainstay of treatment. It's really all the other therapies we have that help reduce that risk of it coming back.
So a lot of options for sure. And anyone just joining us, we are talking to Dr. Sara Fogarty. She is the director of the Breast Cancer Center at GBMC. We're talking about obviously breast cancer health because it is National Breast Cancer Awareness Month. So if you have any questions for Dr. Fogarty, please leave them in the comment section and we will get to them as soon as possible. And, Dr. Fogarty, you've been talking a lot about, the talks that you have with your patients. So it sounds like this isn't something that when you come in and either you concern you have breast cancer, maybe you've been diagnosed, and then boom, you're going to go right into treatment. It sounds like this is really a discussion that you try to have with your patients to make sure that you're giving them the best treatment that works for them.
Right. Absolutely. We usually have a pretty long consultation, 90 minutes that we have set aside for patients so we can go over all of their imaging, their biopsy results, and have a long discussion about what we do for treatment and make recommendations for that patient. And then we start getting everything in motion. And we have a really comprehensive team with our nurse navigator, our surgery scheduler. We have our plastic surgery department in our office that comes every week, so we can facilitate any plastic surgery consultations really quickly. Of course, the cancer center is right across the street from our office, so we have those resources available with the oncology support and medical oncology right there. So it's a long conversation. It is not when we make these consultations, it's really to meet and go over everything and discuss what we need to do for treatment, and then we get everything put in place. And so, people are coming in, we're not operating on them right then. We have a lot of, workup, but we usually move really quickly. It's all we do all day long. So it's a very streamlined process.
Very good. Now you mentioned the plastic surgeon, and a question that we have was if someone wants reconstruction after mastectomy, does that decision have to be made before you get the surgery, or can you do the reconstruction after you heal from your mastectomy?
So we always have anyone that's having a mastectomy meet our plastic surgeon initially to talk about reconstruction options. We always offer immediate reconstruction. Sometimes it's not the right thing for the patient based on what they want, or more rarely now the disease. But we always have that as an opportunity to do during the first surgery to remove the cancer and doing a mastectomy if we need to do that. There are options down the road for reconstruction later. It also depends on what they get for treatment, chemotherapy, radiation after mastectomy that can affect the options for reconstruction, whether it can be an implant or does it need to be your own tissue, what's called a flap reconstruction, where we use a patient's own skin and fat and muscle to reconstruct the breast. That can be more needed after radiation occasionally. But there are a lot of options, and I always recommend meeting with the plastic surgeon before any surgeries happened to get all of the options.
Very good. And actually, we just had somebody chiming in on our conversation asking what types of reconstruction do you offer at GBMC? And you kind of touched on it a little bit, but I don't know if you want to go a little more in depth about it.
Sure. I mean, we most commonly we do either direct implant reconstruction after mastectomy, where we put in a silicone implant in right at the time of surgery, versus a tissue expander reconstruction, which is for women that potentially want to have larger breasts than they had initially, or had large breasts to begin with. We actually, it's like a water balloon. And we basically have that filled weekly until they're the size they want to be. And then they have a second stage procedure where that expander is removed and an implant is placed. So that's what we most commonly do. We also offer a variety of flap reconstructions, including what's called a latissimus flap reconstruction, which is using the back muscle and fat to swing around to become a new breast. We also do tram flap reconstructions, which is using part of the abdominal wall to do that. We also have a microvascular team that offers deep flap reconstructions, which is actually also using abdominal wall, but it includes microvascular surgery to make sure the flap has good blood supply to it. So we do have a lot of options to offer for reconstruction. Again, our mastectomy rate is pretty low, so we don't have that many patients that we do reconstruction on these days, but we have a wonderful plastic surgeon and team from University of Maryland that's here with us in the office 3 days a week, and we're able to offer all types of reconstruction. We also mostly do a lot of lumpectomies with reduction surgery. So patients who are interested in having reduction surgery because they're very large breasted can sometimes have that done at the same time as their cancer procedure. And that's a surgery that a lot of women love. And people do really well with that.
Right. Yeah. So lots of options for sure.
Yes.
Well, let's talk about the men for a second, because I know that oftentimes when we talk about breast cancer, we automatically think of women, rightly so.
Sure.
But I mean, we got to talk about our guys too, because this is something that can impact them. And just, talk about do you see men who come through the cancer center? And if so, how did they get there? Were they doing self-exams? And, are they kind of uncomfortable to talk about this disease, as they probably think it's a woman's disease, but it's really not?
Right. No, we've definitely treated male breast cancer patients in the breast center here. A lot of men just come in because they felt a lump, and they bring it to their attention, to their primary care doctor, and then they get breast imaging done, just the same as women do with mammograms and ultrasounds. We do biopsies to get a diagnosis, and then we have a lot of the same similar conversations with them. Male breast cancers can be a little trickier because usually they're picked up at a later stage, because obviously we're not screening them with mammograms. Again, like I said, with family history and genetics, any male breast cancer that comes through, or if there's been any family history of a male breast cancer, it's always important to have genetic testing done to make sure there isn't a mutation that causes cancer to form. And so that's something that we always recommend for any of our male patients. But we talk about the same treatment with them as with women, surgery, chemotherapy, potentially hormone therapy, radiation. It's all the same discussion and recommendations mostly. They see our same team, and, it's something, we do see. I've had a handful of male breast cancer patients in the last few years for sure. So it's definitely something to note if you have that in your family history, or obviously if you're a male concerned about something, you should definitely get checked out.
Yep. Very good advice. Yeah. And so talking too about, oh gosh, lost my train of thought, but I'll go with this instead. So talking about, you said there's all kinds of resources, both at the Breast Cancer Center and then also at GBMC, and just talk about the importance of having things like, say, support groups, counseling, nutritional counseling. I mean, it's not just the surgical or the medical treatment aspect of dealing with breast cancer, but there's so many other factors that really go into it. And you guys really do have a plethora of those resources available to patients.
Yeah. No, absolutely. We have a lot of resources for patients. We have a really comprehensive, large cancer center for being a smaller hospital. Our oncology support center is phenomenal. They do so many things for our patients, including helping them with transportation, helping them with, sometimes bills that are getting overwhelming if people are sick and unable to clean their house, get groceries. It's amazing what we can help them with during all their treatment. I think, our nutritionist is phenomenal. We have a nutritionist in the cancer center that helps patients who are going through maybe chemotherapy talk about nutrition, talk about diet and exercise for after they've gone through their cancer treatment to help reduce risks of recurrence is really important. Having a normal or ideal body weight, as well as exercising is important, not just for breast cancer, but for just overall health. So we have a lot of resources, and also look, my nurse navigator, Susan, has a whole resource sheet available to every patient. She meets everybody in our center. There's a lot of, centers around and support groups online. Hopewell is a major, support center here in just on Falls Road that a lot of our patients use. There's a lot of online support groups that we have. I mean, getting a diagnosis of cancer, the treatment part can be almost sometimes the easy part. It's the after and the constant worry and anxiety that can come with it. We have an amazing integrative care center here that helps manage the stress of dealing with a cancer diagnosis. And they're available all the time. They do telehealth video visits constantly these days. And a lot of our patients, use them and really have great things to say about how it helped them deal with this diagnosis. So I think based on, of course I'm biased because I do love the center, but based on the large centers around town and anywhere in the country, we have all these resources available to everybody that we can provide and help people get in touch with. So I think it really makes a huge difference for their overall care, not just the surgery and the radiation and the medical care, but it really makes a huge difference for patients.
Yeah, absolutely. I mean, it really is a journey when you get that diagnosis. And it, like you said, it's not just about being treated, but it's also after the fact, after you leave the hospital, and making sure that you're being your healthiest and best self moving forward.
Right. Exactly.
All right. Well, so with all these great treatment options out there now, I'm curious how the survival rate is for breast cancer. I mean, is this something that if you do get the diagnosis, you have to be extremely worried about, or is there more hope that you're able to offer your patients with all these treatment options available?
It's a great question. I think that part of the reason I do this job is because women do generally very well. There are really bad types of breast cancer that are hard to treat. And obviously there are always new medications and new things coming down the pipeline that can help. I think a lot of women have, what we call lower risk tumors or estrogen positive tumors that can be easier to manage and treat. It really depends on what people are diagnosed with. So it's hard to make a blanket statement about that. But I do see a lot of women that have very good outcomes and do really well. And for the early stage, strongly estrogen positive cancers, women can do phenomenally well and not have a problem again in the future. So, compared to 40 years from now, it's a completely different ballgame. Of course, there's so many newer medications, really chemotherapy. There's a certain type of cancer called HER2 positive tumors that has really made huge strides in the last 30, 40 years with different medications to treat them. And women do so much better in those types than they used to. But there's still some really bad kinds that can be hard to manage. So.
All right. Well, before we let you go, Dr. Fogarty, is there anything else you would like to add that you think is good for people to know, both women and men, when it comes to breast cancer? I mean, you kind of touched on the medical, things that we're doing here that sound really great and are moving us forward. And is anything else you would like to add?
I just think that, of course, in the time of pandemics and COVID, of course, we're up and running at full speed with mammogram screening again. And if you have a concern, to bring it to the attention of your doctor. I mean, sometimes it's absolutely nothing, but sometimes it's not. And I think it really makes a difference if you just get that checked out. And so we're always here, we're available to see patients all the time. So that's really it.
Mammograms aren't that bad, I think.
No, they're not.
I think people make
Some
them.
People hate them. They're not fun, but they're not that bad. I mean,
and it could save your life.
It could be much worse. And it's always, nothing's perfect with imaging, but it's very helpful if we have that done just to make sure we're not missing something. It's amazing how small the tumors can be that they pick up. So I think it's really important to get back on track with your screening. And if you're worried about anything, to call your GYN, call your primary, just get checked out and make sure it's nothing. Okay.
Absolutely. All right. Well, Dr. Fogarty, thank you so much for joining us on our Facebook Live discussion. And if you're just tuning in now and you want to see from the beginning, we're going to post it on our Facebook page as soon as we end the Facebook Live portion here. So again, thank you so much for joining us. A lot of great information today.
Thank you so much for having me. I really appreciate it. Take care.